This is Nazir Habib. I would like to today discuss first in a series of talks on capnography monitoring in critical care. The most common approach to looking at end-tidal CO2 in the ICU is to ignore the value and not interpret the clinical situation and move on. This is often a problem in the management of the patient, especially with mechanical ventilation. So let us review what is capnography. Capnography is a non-invasive continuous measurement of exhaled CO2 concentration. Capnography provides respiration rate and a numerical value which is displayed on the screen. Let us review the use of capnography in the ICU patients, as this is somewhat an uncommon practice in many ICUs. Let us look at what end-tidal CO2 evaluates. Basically, when the patient is breathing, oxygen enters into the circulation and CO2 is produced in the organs and tissues and is brought back to the alveoli with cardiac output from the right ventricle and is exhaled. And that is what we're measuring when we place an end-tidal CO2 monitor in our patient. So in review, oxygen enters into the lungs and is carried to the tissues. And as a result of metabolism, CO2 comes out. The process of eliminating CO2 from the body is extremely important, as if it is inadequate, it leads to CO2 retention and altered mental status and respiratory acidosis. So in order for CO2 to be eliminated, we not only need mechanical ventilation or spontaneous ventilation to be adequate, however, we also need to pay attention to the perfusion of these alveoli. As the cardiac output comes from the right ventricle, this may show many problems. So what are the normal values? The normal values of PCO2 in the blood, as we know, is usually 35 to 45. Most normal patients have PCO2s in the range of 38 to 42. Normal end-tidal CO2 value is generally 3 to 5 below the arterial PCO2 value. So in the operating room, when a patient is intubated with normal ventilation and perfusion, the patient's end-tidal CO2 is around 35 to 38. The way the end-tidal CO2 is measured is very simple indeed. There are two different types of tubing. One is for a patient who is spontaneously breathing, which is orange, and a patient that is on a ventilator, the tubing is yellow in color. So what is the difference between capnography and pulse oximetry? Well, obviously, pulse oximetry reflects oxygenation and measures the O2 sat. This is often not a reliable indicator of worsening respiratory failure, as it doesn't measure the PCO2, and the patient may be hyperventilating, and there will be a delay in the decrease in oxygen saturation, especially if the patient is on supplemental oxygen. So capnography is a more accurate reflection of the patient's adequate ventilation. It measures the CO2 that is exhaled. Therefore, if the patient is hypoventilating, the end-tidal CO2 will increase, and this is often a sign that the patient is developing respiratory acidosis. So let us look at the normal CO2 waveform. The A to B here is the baseline, which should be 0. The wave rises rapidly from B to C, which is the exhalation part, which is the upstroke, which is rapid, and you reach an expiratory plateau. The end-tidal value is actually D, which is when the terminal alveoli are empty, and then the inspiration and the next cycle begins. So what is the value of end-tidal CO2? Well, initially when the patient is intubated, it helps you assess the placement of the endotracheal tube and the circuit integrity. It also allows you to measure adequate ventilation and initiate ventilator settings based on what the end-tidal CO2 is upon intubation. Again, patients with normal VQ perfusion should have an end-tidal CO2 of around 35, and that will help the respiratory therapist to adjust the respiration settings on the ventilator. It also allows you to ensure that there's adequacy of pulmonary perfusion or adequate cardiac output, which is very important, especially when the patient is in shock or the patient has a cardiac arrest. There are many clinical situations that end-tidal CO2 is of benefit, and I will review such clinical conditions in the second part of the series of talks on capnography. So there are many factors that affect the end-tidal CO2. CO2 production itself may be increased due to fever, seizures, excessive muscle activity. Even IV bicarbonate infusions will increase the end-tidal CO2 as it releases carbon dioxide. It also assesses the carbon dioxide delivery or the blood flow from the peripheries as the blood is carries the CO2 to the right ventricle, and then it is eliminated. So it helps you assess the right ventricular cardiac output as well as the adequacy of mechanical ventilation or spontaneous ventilation. So what is the relationship between the arterial PCO2 that we measure on the blood gas and the end-tidal CO2 that we're observing on a patient in the ICU? This is where the disconnect often occurs, because the end-tidal CO2 may be high or low, and it is therefore ignored, when it truly is a reflection of the physiological status of the patient. I will reiterate that the end-tidal CO2 normal range is 35 to 40. If the patient has chronic CO2 retention, such as a COPD patient or an obesity hyperventilation syndrome, the end-tidal CO2 may be much higher depending on what the patient's baseline CO2 is. So don't ignore that. Ideally, under normal VQ circumstances, when the ventilation and perfusion are very well matched, as in a normal patient who is not in the ICU, the difference between the PCO2 and end-tidal CO2 is 2 to 5. In reality, in the patients in the intensive care unit, the ventilation and perfusion are rarely fully matched, especially when a patient is intubated. They may have COPD, they may have a low cardiac output, they may be in septic shock, and therefore, in each patient, there is physiology in the lung, which we call either dead space or shunt, which may often coexist, and the end-tidal CO2 is very useful in managing such critically ill patients. So let's look at the end-tidal CO2. The end-tidal CO2 is low. Often you're dealing with dead space, which means that the patient is either excessively ventilated or inadequate perfusion from shock or low cardiac output. The diagnosis really here, when there's a big difference between the PCO2 and the end-tidal CO2, is that you have either hypovolemia, low cardiac output, excessive ventilation, excessive tidal volume, possibly excessive PEEP, and possibly a pulmonary embolism as being examples, and checking an echocardiogram to assess the right ventricular function, as well as looking at your ventilator settings may be very useful. On the other hand, we have shunt physiology, which people often get confused between dead space and shunt. Shunt means that the patient has adequate perfusion, however, the ventilation is impaired. What it means is that the alveoli are unable to allow gas exchange. This is often a result of mucus plugging, blood, and the common situation is pneumonia or ARDS. In this situation, the difference between the PCO2 or arterial CO2 and end-tidal CO2 is often small. And what you're dealing with here is probably shunt physiology, such as ARDS or pneumonia. In this situation, it is best to check the chest X-ray for whiteout or pulmonary infiltrates or pneumonia and suction the patient. This is a area where you may actually have to increase the PEEP to recruit the alveoli. In a patient with dead space, one has to consider decreasing the tidal volume and decreasing the respiration rate and allow for better perfusion of the alveoli. So increased dead space is often ignored in the ICU. This is a common situation, especially in patients with shock, hypovolemia, pulmonary embolism, right ventricular failure, especially COPD or asthma patients, or when patients are receiving excessive tidal volume or PEEP and the patient's pulmonary perfusion is occluded. So the difference between the PCO2 and the end-tidal CO2, which I refer to as the gap between these two values, is normally 3 to 7. The higher the gap, the higher the difference between the ventilator settings are probably not optimal. So if you have a patient with a PCO2 of 80 and an end-tidal of 20, what you're dealing with is dead space ventilation, and you're creating air trapping and increasing the respiration rate or tidal volume of PEEP to improve the patient's PCO2 or O2 will worsen the difference between these two values, and the patient will do very poorly. The other areas where end-tidal CO2 is very useful is looking for a leaky or deflated endotracheal tube that is becoming dislodged. You will see normal waveform deteriorating where the waveform does not reach the plateau and quickly deteriorates. A loss of a waveform in a patient who is mechanically ventilated could mean that the patient has disconnected ventilator or dislodged airway, maybe a self-extubation. However, if you look at the patient and the patient is still intubated and there is no circuit leak and the patient has not come disconnected from the ventilator, the patient is having a cardiac arrest. On the contrary, if the patient has a good end-tidal CO2 and the patient's arrhythmia may be rapid, VTAC, etc., the patient is not dead and CPR does not need to be initiated unless the end-tidal CO2 is rapidly falling and is below 10, at which point one should initiate CPR. CPR recommends currently that end-tidal CO2 is utilized during chest compressions. The end-tidal CO2 in the cardiac arrest is 0, as there is no perfusion to the alveoli from the ventricle. As you initiate CPR, you should be able to get end-tidal CO2 readings above 20. The end-tidal CO2 rises above 20 with return of spontaneous circulation as well. However, a persistently low end-tidal CO2 after 20 minutes of CPR indicates poor survival and lack of cardiac response and is associated with very poor neurological outcome. So it can also be used to detect efficacy of CPR as well as return of spontaneous circulation and help you prognosticate whether one should continue CPR beyond 20 minutes in a patient with poor underlying cardiac or pulmonary function. Another area where one can look at the end-tidal CO2 is to determine if the patient has an occluded airway, and often we can detect bronchospasm with the shark fin appearance that is seen in this graph. This is a very good sign that the patient still has bronchospasm, even if you cannot auscultate with a stethoscope, the patient is still having bronchospasm. End-tidal CO2 may also be used in non-intubated patients, as you've seen. And this is often used in patients with procedural sedation and often patients who may be at risk of hypoventilation from narcotics if they have obesity hyperventilation. I also recommend using end-tidal CO2 monitoring with a nasal cannula when I'm treating patients with massive or submassive pulmonary embolism, and we will discuss this later in another series. So end-tidal CO2 is very useful in determining endotracheal tube placement and maintaining correct position of endotracheal tube, and monitor for dislodgement, evaluation of adequate ventilation and perfusion, and detect dead space. Also, it tells you about the pulmonary perfusion and cardiac output, especially when it is used in combination with an echocardiogram at the bedside. It helps you assess the ventilator settings, including tidal volume and PEEP. It also helps you detect obstructed airways, airway leakage or loss of an airway, and recognition of code blue in the ICU, as well as help you perform adequate CPR and detect return of spontaneous circulation. So in summary, it is very important to ensure that end-tidal CO2 becomes a standard of care in the management of your patients in the ICU. It is very helpful in managing the ventilator settings, detecting bronchospasm. During weaning trials, an increase in PCO2 of 8 to 10 should lead to stopping the weaning trial or at least check an arterial blood gas. We can also detect perfusion abnormalities such as pulmonary embolism, cardiac shock, low intravascular volume, low cardiac output. Also, it is very useful to titrate optimum PEEP in ARDS. I use the term mind the gap as this difference between PCO2 and end-tidal CO2 is often a sign that dead space is being created with excessive PEEP. These are some references. If you wish to review this topic any further, thank you for your time and attention.